The first presentation will be given by Professor Ramon Grimald. Professor Grimald is Professor of Dermatology and Pediatric Dermatology at the International University of Catalunya in Barcelona. He is past president of the European Society for Pediatric Dermatology and board member of several societies in the field of pediatric dermatology. Hair disorders is one of his main fields of interest, so it's not surprising that today he will tell us more about hair loss in children. So Ramon, the floor is yours.
Beste vrienden, beste collega's, goedemiddag. Ik ben zo blij om jullie te zien, maar ik ben erg moe van zoveel virtuele conferenties. De laatste paar maanden heb ik Nederlands gestudeerd, maar het is niet genoeg om mijn les in jouw taal te maken. Dus ik zal het in het Engels doen. For all of you not understanding Netherlands, I am sorry you were not laughing as much as Dirk it is for my accent. I am just saying I'm so glad and happy to be here on this meeting, and I am tired of virtual meetings, but it's part of our life, so we shall be here. My talk will be on hair loss in children, and I'll try to do a short update about that. This is the University of Milano, where I studied pediatric dermatology many years ago. Here you can see a picture of myself on the left, together with Carlo Gelmetti on the right. This was in 1991, and unfortunately, my friend Raffaele Gianotti, who was a son of Ferdinando Gianotti, the one from the syndrome of Gianotti-Crosty. He passed away a couple of months ago, which I'm extremely sad for the family of them. My two topics will be covered today only because I think it will be more interesting if we focus, and I've chosen alopecia areata, and I've also chosen self-inflicted hair loss. Let me minimize that. Okay, I'm sorry. Let's just start with alopecia areata. There are several articles dealing of new aspects on alopecia areata, and in this one, they discuss about some seasonal patterns. We all know that alopecia areata, it's related to a gene defect, and you are prone to get alopecia areata when you are born, and then a trigger may lead you to show the disease. So you cannot have alopecia areata if you decide to, but you have to be born to have it. But usually we decide that most triggers are anxiety, stress, or in some cases infections. In this article, they found that seasonal patterns have been involved in many cases. And in fact, when we think about that, we see many cases that get back on spring. They studied nearly 500 children with severe forms of alopecia areata, and they tried to register what was the month of onset. And they found that there might be a seasonal pattern and a predilection for flares during colder months in that study. In patients with alopecia areata with atopy or with historically cyclic flare patterns, it may be reasonable to recommend prophylactic antihistamine therapy during high-risk flare month, even though we do not consider alopecia areata to be an allergic reaction. Some of these patients seem to be related to the flare-ups in their allergy diathesis. So that's the reason they decided to put that. Evidence supporting this antihistamine therapy for alopecia areata, it's indeed limited, but by inhibiting the T-cell migration and the T helper cytokine production, these medications might interfere with CD41 T-cell driven inflammation that contributes to hair follicle destruction. What about ustekinumab? This is a nice report, and they treated in a couple of years ago 3 pediatric patients with alopecia areata, and they had this monotherapy of 19 milligrams, and they had this moderate response on all of them. They followed them for 4 months, and they had this not a spectacular result, but I could say quite acceptable to show that ustekinumab works on getting back the hair. And in fact, the JAK2 inhibitors are in the mouth of every pediatric dermatologist. JAK2 inhibitors are now very fashion, and all patients have heard about that. And they come to your clinic and ask, are you going to give me a JAK2 inhibitor? And there are these three mostly used JAK2s, the ruxolitinib, the tofacitinib, and the baricitinib. You all know that the first one works mostly in 1, 2. The tofacitinib is a JAK3, and the baricitinib is 1 and 2. There are many papers dealing about the use of these JAK inhibitors on alopecia areata, and we all know that these are serious drugs to be used in not a so severe disease. So it's not easy to try to tell patients if this is worth or not. And we all look forward to see how topical JAK inhibitors will probably in the next future solve that kind of ethical problem we pediatric dermatologists have. Should we treat our children with oral or intramuscular or intravenous JAK inhibitors for such a not so severe disease? Well, this paper deals on this topical application of JAK2 inhibitors. In this case was tofacitinib and ruxolitinib in 1 and 2% creams, and they show a slightly good results. And this is another paper also showing tofacitinib 2% ointment as being an ointment, probably the capacity of penetration increased. So in this case, they treated 10 patients and they had this nice response. Half of the scalp was treated and the other half of the scalp was not. And you can see some of the patients showed a result with this ointment of tofacitinib. They had one patient and partial regrowth on 2 other patients. The paper from Antonella Tosti trying to review all the drugs that have been used on alopecia areata, try to show if it's worth or not. And they state on that paper that topical showed poor results, especially compared to the oral formulation. So even though we all think that the future might be topical JAK2 inhibitors and non-systemic JAK2 inhibitors for this disease, they still do not get insight enough to get the results we are looking for. From the conclusions of this paper from Matilde Llorizzo and Antonella Tosti is that JAK inhibitors are not able to sustain remissions when the cure is stopped. And obviously we cannot keep the patient with the same drug for a long period. So there's neither a validated dosage for alopecia areata, and the vehicles used for topical formulations seem not yet ideal in terms of skin penetration. This is a nice systematic review and meta-analysis trying to better understand how JAK inhibitors work, and they state that there's probably not enough evidence in order to maintain the treatment in these patients. In the last couple of years, other type of papers appeared and they were quite interesting because in the last year, most of the papers, they were just dealing of COVID problems and COVID-related hair loss in children and other type of problems. And we have to go a little bit back, trying to see what's new really on this disease. And they get back to a very old drug, hydroxychloroquine. And they use hydroxychloroquine with excellent results. Hydroxychloroquine, it's very cheap, and we dermatologists are used to use it for other diseases, so we are not scared of these drugs. It's not difficult to find, it's not difficult to use, and the results are so nice as you show in this patient. They just treated 9 patients and they had 5 responders, so it's not spectacular, but it was not patchy. They were total and fully affecting hair alopecia areata patients. They had this mean SALT score reduction of 3.2, so it was not a bad idea. Also, methotrexate, it's a very cheap drug, and we use it for many years for other diseases like psoriasis, so we are not scared neither of this drug. and they went back to see what are the results, because sometimes we lose focus. And when a new drug appears, everyone is interested in treating patients with a new drug. And when we see good results, maybe 20, 30% of response, we state, wow, this drug is really working. And then we go back to all the drugs and we see that we get with those drugs maybe the same amount of responses. And those drugs were not as harmful, were not as expensive, and we know how to deal with them. So it's good to look back a little bit time in time. They treated 14 patients from the age of 3, quite young, up to 17. And they had these results, which are quite good in the pictures, as you can see in here, and all of the patients treated. 11 of the patients finished the study. 3 had a partial response, 8 had a good response, which is not bad at all. And 4 of the patients experienced complete or nearly complete regrowth. So you can see that methotrexate, which is an old style drug, might really work also on that. This is a nice review from Pelukin and Castelsocho, trying to see what's new on alopecia areata up to 217. And they discuss a little bit these psychiatric implications. We all deal with patients with alopecia areata, and we know that adolescents and children have low quality of life. So it's not so easy to try to distinguish if these alterations in their mood are related to the disease or are a consequence of the disease. So in this paper, they discuss these facts, and it's quite interesting to have a look of what they feel. Let's change to the second part of my talk, and we shall discuss a little bit of artificial hair loss. You can have artificial haircut, like these patients that I saw lately. Some of them just put a plane on their skin. Others do sophisticated types of hair styles, like this one, or even this one in 3D. You can get an animal on your head like that. So artificial hair loss, because patients suffering from artificial hair loss, they complain of hair loss, but in fact, they are not losing hair like in the barbershop. But we can use self-inflicted hair loss or self-induced hair loss for better understanding ourselves. Let's start with some Greek. Trichotillomania, trichophagia, trichotemnomania, trichoteiromania, trichorhizophagia, tricholeichomania, and trichodagonomania. We won't discuss all that, but we shall have a fast look to most of these names. Trichotemnomania is those girls, usually adolescents, that use scissors to cut the hair in a funny pattern. Very similar to the patients I just showed you from the barbershop, but they do it by themselves. They do not go to the barbershop. And then they come to you saying, I'm losing my hair. And they're not losing the hair, they are cutting the hair, and that's the aspect. So they can get. This is a patient normally cutting the hair. This is another patient from, this case is from Charité in Berlin, from Professor Ulrike Blume, Italy. There's another variety of tricho. In this case, it's called trichoteiromania, in which patients are not cutting, but they are rubbing frenetically their hair. So by rubbing them, they break it in small pieces. The plaques are not so well limited, as friction is not so precise. And you can see these dirty looking plaques on patients suffering from trichoteiromania. Another patient with the same disease, a funny looking one with this so not well marked pattern of distribution. So in trichotillomania, hair is plucked. In trichotemnomania, hair is cut. In trichoteiromania, hair is rubbed. There was a paper last year in which trichotillomania was triggered by vitamin D deficiency. So everyone decided that we should give vitamin D to these patients in order to help them having that. It's one single case, so I would not waste any time or any money giving vitamin D to our patients suffering from that. Some of the patients we see have very long hair, extremely long anagen phase. This one, it's maybe 8 or 9 years growing anagen phase. And from that patient, you can get an idea of what's going to happen. Imagine if you pluck your hair and you have a tendency to eat your hair. If you have short hair, this will not be a problem. If you have long hair, this might be a problem. This was a 21-year-old pregnant female at the 33 week of gestation suffering from bipolar disorder, and she came to the hospital for a management of abdominal pain. She was pregnant, she had a bipolar disorder, so everyone thinks of something different. But when they had to go into surgery, they found this enormous trichobezoar on her stomach. So they put this funny name on the article, a fairy tale with a hairy tail. Trichobezoars derive from the Arabic word batzer, which is translated as an antidote. And bezoars originate in the digestive tracts of animals, and they were used as an antidote against plague, snakebite, leprosy, or even epilepsy. Some of the patients really grow enormous amount of hair inside of their stomach. They don't really grow it, they just accumulate it by eating it. This is another case causing the Rapunzel syndrome. What is the Rapunzel syndrome? You remember that lady on the high tower just putting the hair down from the window in order that his beloved could climb up during the night to spend the night with that princess? That was Rapunzel. So this is not so nice looking. If you think of Rapunzel, you think of another thing, but this is the aspect of a trichobezoar extending on the thin intestine. How can we treat trichobezoas? Well, what about Coca-Cola? Well, some articles have still trying to see if the use of Coca-Cola might be useful. So they introduced via nasogastric tube direct injection and a sprite through endoscopy to these patients. And they tried to divide the bezoar in 4, and they incubated with Coca-Cola, Sprite, soda water, and distilled water. And they were measuring the amount every 12 hours and for 7 days. And they were measuring change in weight, density, and form. And they had no changes. So even if some patients may think that this might help, in fact, it's not. But I was really astonished to see that there are other papers dealing about that. So it's not just patients thinking of how it works, but it's also some researchers trying to see if it works or not. So in the first article, Coca-Cola can effectively dissolve gastric phytobezoars, but not trichobezoars. And in the second one on the bottom, in vitro analysis of gastric phytobezoar dissolvability by Coca-Cola, Coca-Cola Zero, cellulase, and papain. I know you are really surprised as I was about reading these papers. What's trichodagonomania? It's the compulsive habit of pitting one's own hair. And this was published in the Blue Journal in 2009, trichodagonomania. Then a new article appeared a couple of months later saying trichodagnomania instead of dagonomania, but it's a long discussion of Old Greek and New Greek. We should say trichodagono or trichodagno. But this is a compulsive habit of pitting not your own hair, but someone else's hair. And then you can get this disease, we call it by proxy. I decided to have an experiment at home. I have this cat at the top right on the image, and I have this dog on the left of the image. And I applied some intense flavored food in both of my arms, one in the left and one in the right. And I had my cat licking my left arm and my dog licking my right arm. And I was trying to see the differences on the amount of epilation by the very rough tongue of my cat and the not so rough tongue of my god. And this was published last year in the Clinical Medical Research with the name of trichotillomania by proxy, the compulsive habit of licking someone else's hair. This has not yet been described in humans, just in animals. What about treatment of this self-induced hair loss? It's not easy to treat these patients. And in N-acetylcysteine, this was published and everyone started treating patients with this drug. This is a very cheap drug. It's available. All pediatricians know very well this drug because it's used for other type of problems, mostly Lyme-related problems. And this was the initial paper in 2009. They used for 12 weeks a double-blind, placebo-controlled, high doses of N-acetylcysteine with excellent results. And it is very good results in 9 weeks. But then a good review showed that these results were not so well performed, and this should be re-seen and re-understood a little bit. Together with a friend of mine from Venice and a friend of several of you, Dr. Mario Cutrone, we published this special case. This was an adolescent who came to visit us because this very strange aspect on the beard. And he was complaining of this problem, and he was not explaining what the problem was. And the reality, after plenty of time discussing with him, was that he was the first one in his school to grow the beard. And he didn't like it. And he didn't want to be older than the others. So he spent hours in the mirror on his bathroom using the forceps that the mother used for the eyebrows, just plucking all the hair from his beard. And we saw these results on the dermoscopy. And this was a very special selective case. In 2019, Brown did these randomized control trials to try to understand if this was working or not. So N-acetylcysteine probably is not a good idea for treating our patients affected by self-induced hair loss. And with this image of my former professor, he was the one who told me everything I know. He was my mentor, my friend, and my professor. And unfortunately, he also passed away 8 years ago. This is Professor Ruggero Caputo from the University of Milan in Italy. And with this nice view of Barcelona before the pandemics, I invite you all to join us to have some friends there. You can see Dr. Dirk Van Gysel and Mario Cutrone and Talia Kakuro and also Barbara Kunz in there. And I can also see maybe Ulrike Blumer in the same picture. And if you are interested on here, I'll be happy to invite you all to come and visit us in Sitges next year at the end of September. We're having an international hair meeting. We shall be discussing pediatric hair problems as well as adult hair problems. You can check in the website barcelonahair.org with the idea of getting some information and updates about that meeting. And with that, I'll be very happy to answer any questions you may have. Thank you very much for your time.
Ramon, you are really amazing. After 6 months of practice, you speak better Dutch than 45% of the Belgian population. First question, what is your first line treatment of alopecia areata? In children?
Yes. I think that as I'm getting older, I am starting of treating less patients with alopecia areata. I would say that we have approximately 80% of the spontaneous regrowth on patchy alopecia areata. So the first line is not treating patients and explaining them what will be probably the results. Most cases of patchy alopecia areata will solve without any treatment. In severe cases, I think we have to be very cautious before starting systemic treatment, because many patients will be very excited about the results, and adolescents might be extremely happy about the results. But then when you have to stop the treatment and it's impossible to maintain the treatments that really work, they are impossible to maintain, they will suffer again, and sometimes they will suffer more. So when you decide of starting methotrexate, that will be probably one of my first approaches, or oral steroids. Now we are using this bolus of steroids twice a week, or you decide to go for intralesional steroids that in children I don't like to do, but in some cases we might use them. You always have the same problem. So after treating so many patients and seeing what's happening 6 months or 1 year later, it's not so crazy to try to explain them that it might be a good idea not to treat them seriously. But I know that not everyone agrees with that, and I am obviously open to hear other options and other opinions indeed.
Is there a place for difensiprone in children, or you would not do it in children?
Yes, I think difensiprone, it's the only drug that Professor Rudolf Happler once showed. He was the first one to show that applying half of the scalp with difensiprone, you get the result. The other topical drugs, you cannot show these results. And today I showed you some images of YAC2 inhibitors topically applied, and they did not show a so clear-cut result. But with difensiprone and with PUVA therapy, you can get that. I would say PUVA therapy can induce skin cancer, so I don't use it in children. But difensiprone has no big secondary effects in the future, and it can be maintained. So it's a very good option. The problem is that it's not easy to perform, and if you don't have very good trained nurses, and if you don't have patients coming not from far away, it's not easy to manage. So I think it has to be used only for very selected patients that they know how to come, when to come, they are close to your clinic and you can apply it. I don't allow them to do it at home, so you have to apply it by yourself. So in practically, because many patients come from different cities, in the practical, it's not so easy to perform this treatment, but I agree that this is a non-harmful treatment and highly effective.
And what about minoxidil?
I think now that there's not anymore any scientific evidence that minoxidil is working on severe forms of alopecia areata, but I agree that in many non-severe cases, like patchy forms, it's a good option to apply lotion with maybe a topical steroid and minoxidil mixed together, and patients will be happy because they heard about the properties of minoxidil on hair. But the pathogenesis of the disease and the method of working of minoxidil, probably they don't have a mixing that works together. So I don't think that there's an evidence that if the patient is growing hair after applying minoxidil, this regrowth is related to this drug.
Okay. Barbara, do you have further questions?
Hoor ik een vraag?
I think there are no more questions from the audience. So thank you, Ramon, for this excellent talk as usual.
It was my pleasure. Thank you very much for your invitation, Dirk.
Yeah, with pleasure. So we move on to our next speaker, which is Dr. Julie Leysen. Dr. Leysen is dermatologist. She's working at the Department of Dermatology of the Antwerp University Hospital in Belgium. She is board member of the Belgian Society for Pediatric Dermatology and one of the rising stars in the field of pediatric dermatology. And today she will tell us more about nail changes in children. So Julie, there you go.
We don't hear you.
Julie, we don't hear you. You must unmute yourself.
It's pre-recorded, so it will start in a moment, I think.
Ah, okay.
Hello, good afternoon. I'm very pleased to introduce you in the world of nail diseases in children. These are the learning objectives of my presentation. I like you to differentiate physiological from pathological nail changes in children, to get an overview of the main nail diseases in children, and to recognize nail disease as a window to internal disease. This is an overview of how my presentation will look like. First, I will start to get to know you the normal nail units. After that, I learn you the physiological changes, go into nail diseases, congenital as well as acquired, and I will end with nail disorders as a sign of systemic pediatric disease. The nail plate is the hard and translucent portion of the nail unit. It's composed of onychocytes, which we normally clip here at its free edge. It's bounded on three sides by the proximal and the lateral nail folds. The cuticle seals the nail plate from the outside environment at the proximal nail folds. The nail matrix is located beneath the proximal nail fold and is the epithelium that creates the nail plate. The nail bed represents the epithelium and connective tissue on which the nail plate rests. The hyponychium, to end with, is a distal aspect of the nail unit at the junction of the free edge of the nail plate and the nail bed. So we move on with the physiological changes. As you see in this table, depending on the age category, we see different physiological changes of the nails. We start with newborns. Newborns can present with koilonychia. This is also called spoon nails. Koilonychia describes nails with a transverse and or longitudinal concave nail dystrophy with a central depression. The term spoon nails describes the flattening in the middle with an everted lateral edge. Spoon nails or koilonychia has multiple etiologies. It can be hereditary, acquired, or idiopathic. It's frequently idiopathic and present in 32% of cases as a normal variant. And it spontaneously regresses when the nail plate thickens, and this happens at the age of 9 years old. It may be as well a manifestation of inflammatory skin disease, such as psoriasis or lichen planus. Or it can be secondary to systemic alterations, such as iron deficiency, Plummer-Vinson syndrome, or endocrine disorders. In this picture, on top, the clinical picture, and down dermatoscopy, we see transient physiological onychoschisia. This happens mainly on the big toes and thumbs with transverse and lamellar splitting at the free edge in early infancy. We move on with the bolt lines we often see in infants. Bolt lines of the fingernails, they appear at 4 weeks of life in 92% of newborns, and they disappear with growth before 14 weeks. This phenomenon describes a single transverse depression of the fingernails, as you see it here and here. Both lines, they result from intrauterine distress or physiological alterations during birth. They are transverse nail plate surface depressions resulting from mild trauma to the proximal nail matrix with transiently reduced nail growth. Next one we can see in toddlers is the punctate leukonychia. We often see it in the fingernails. Children usually are affected by true leukonychia that occurs due to the trauma to the distal matrix. Transverse leukonychia is quite rare in children. It's typically restricted to the toenails. This variety of true leukonychia is due to trauma, from shoes to a thick nail plate, which transmits the trauma to the distal nail matrix, resulting in a periodic defective keratinization with the production of one or more transverse white bands that move distally with nail growth. Toddlers can also present with pitting. Pitting are superficial punctate depressions of the dorsal nail plate. Here we see it very subtle. Later on in the presentation, we will see more pronounced nail pitting as a sign of systemic disease. What do we see in preschoolers? In preschoolers, we can have chevron or herringbone nails, where we see that the nail plate shows an oblique and longitudinal diagonal ridges converging towards the center of the nail plates. As you can see here, it describes a central spine with the appearance of a V shape or a chevron. It appears between the age of 5 and 7 years, and it disappears in early adulthood. It affects several or fingernails with an undetermined etiology. On this picture, it's a girl of 7 months old, which is otherwise completely healthy. So we move on to the nail diseases. Nail diseases are actually quite uncommon in little children, and they can be subdivided into different groups: congenital nail disease or acquired nail disease. And we start with this group, the congenital nail diseases. First one is the congenital malalignment of the big toenail. It's an isolated nail condition, probably caused by an abnormality in the ligament that connects the nail matrix to the periost of the distal phalanx, or due to an excessive traction by a hypertrophic extensor tendon of the hallux. The condition is often bilateral and may be complicated by the development of lateral or distal embedding, which is more frequent when hypertrophy of the lateral nail fold is associated. The affected nail may be thickened, like we see here, with a little bit of a triangular shape, and a surface changes due to repetitive traumas. This spontaneously heals in about 50% of cases. Surgical treatment is recommended for severe cases that do not tend to improve spontaneously, and then surgery is performed at the age of 2 to 5 years old. Next congenital nail disease is the Pachyonychia congenita. This is an autosomal dominant inherited condition due to mutations of 4 keratin genes. And it's characterized by early development of nail thickening with an increased curvature due to nail bed hyperkeratose. And it's always associated with palmoplantar keratoderma. Nail and skin changes are present at birth in only 50% of cases, but by 5 years of age, they are seen in more than 75% of cases. By the age of 10 years, most of the children complain of pain, and this can greatly impair the impact of life. And the most common finding is the thickening of the toenail. The next one is the nail patella syndrome. This is also a congenital inherited disease, also due to a mutation of the gene LMX1B, and it's inherited in an autosomal dominant pattern. Nail hypoplasia is associated with bone and kidney abnormalities, and the nail changes, they may be limited to the fingernails, usually the thumbs, with hypoplasia or absence of the nail plate. Triangular lunulae are also characteristic. Bone abnormalities include absent or hypoplastic patella, radial head abnormalities, and iliac crest exosystose. Pelvis X-ray permits the diagnosis of nail patella syndrome in children. It's important to get this diagnosis because this can prevent the severe kidney damage. So we move on with the second part of nail disease, the acquired nail diseases. These are also very uncommon, but in this category, we mostly see inflammatory or infections. So we start with the inflammatory nail disease. They can be isolated or they can be with skin lesions. The first one is lichen planus. The nail involvement by lichen planus is less common in children than in adults, occurring in about 14 to 20% of cases. As in adults, lichen planus may be limited to the nails, even in children. The nail findings are usually mild, with several nails showing thinning, longitudinal ridging, tracheonychia, discoloration, and nail dystrophy. These cases where we see a very strong involvement, they require a longitudinal nail biopsy to confirm the diagnosis. For example, when we see a nail pterygium, it's an uncommon outcome, but then you need systemic therapy with steroids for 3 to 5 months. That's advisable. In this picture, we see a mild, a moderate, and a severe nail lichen planus. And the mild, we note the longitudinal ridging and splitting limited to the distal portion of the plate. The onycholysis is mild and nail bed hyperkeratose is absent. On the moderate lichen planus, we see also this fissuring, we see longitudinal grooves and distal splitting. There is also mottled erythema of the lunula, and this can be roughly observed in the second fingernail, like here you see. Onycholysis is more marked and nail hyperkeratose can be observed in the thumb as well. The last one is the severe one. We see complete fissuring and splitting, and also diffuse erythema of the lunula. So as I said, nail pterygium is an uncommon outcome, but then you need systemic therapy with steroids for 3 to 5 months. This is advisable, as we see in this article of the JAT. This is a case of our own hospital, an 8-year-old girl before treatment and after treatment, where you see a nice result, especially in this finger, you see the nail getting better. Next inflammatory nail disease is psoriasis. Psoriasis is more rare in children than in adults, occurring in 10 to 40% of the children with skin lesions. It can also be limited to the nails. It can precede or it can develop with skin lesions. The clinical manifestations, they are similar to those of adults, but in children, they are usually mild and frequently go unnoticed, as well by the child as by the parents. Fingernail pitting and toenail thickening with subungual hyperkeratosis due to accumulation of scales under the nail plate are the most common signs of psoriasis in children. Psoriasis pits, like you see here on the nails, they are usually large, deep, and irregular. Toenail thickening may involve one, several, or all toenails and may result from nail plate thickening due to matrix psoriasis or nail bed hyperkeratosis. In these cases, differential diagnosis with onychomycosis may require mycology. When you notice nail changes in psoriasis children, one may want to know whether this predicts something of the course of the psoriasis. What we so far know from literature is that nail involvement may indicate increased risk for both overall disease severity and development of psoriasis arthritis. And there are nail findings. If there are nail findings at the initial presentation, the PASI scores at 2 years of follow-up are higher. So identification of pediatric psoriasis patients with nail psoriasis may be helpful for predicting which patients are at risk for more severe disease course. The next one is tracheonychia, or also called 12-20 nail dystrophy of the childhood. It's characterized by nail plate surface abnormalities appearing as nail roughness, resulting from a mild inflammation of the nail matrix. It's also called sandpapered nails, rough nails. One, several, or all nails may be affected with this diffuse roughness. But trichonychia is rather a clinical sign than a diagnosis. This is a picture of rough trichonychia, as you nicely can see here. So with this clinical sign, I want to tell you there are two main types of trichonychia. You can divide it. So you have the idiopathic, isolated nail involvement in the absence of personal history or signs of dermatologic disease. But there is also trichonychia with a past history or coexistent clinical evidence of alopecia areata, lichen planus, psoriasis, and atopic dermatitis. And of course, this has influence on the treatment. If it's really an idiopathic form, it's benign and non-scarring and it resolves spontaneously. But this is the reason a comprehensive skin exam is essential in all patients to look for associations. Another important thing is that it's often misdiagnosed as onychomycosis, so it's essential to perform lab studies before the initiation of antifungal therapy. Another nice inflammatory nail disorder is lichen striatus, as you see on this clinical image here on the left with dermatoscopy on the right. It's rare, but it's almost exclusively seen in children. One digit, usually a finger, shows nail abnormalities. It's longitudinal fissuring, thinning, and distal nail splitting. And it's restricted to one side of the nail. The nail changes, they may be isolated, but they can also be associated with the typical skin lesions as seen in this girl, where you see this lichen striatus typically on the leg. It regresses spontaneously in a few years, although some cases with long-lasting course have recently been reported in literature. In our case, the skin disease was healed well with a combination of a topical therapy with tacrolimus and a steroids. We move on to the next category. These are the infections. Infections can be warts, onychomycosis, hepatic whitlow. The three most important ones are the bacterial, paronychia, fungal onychomycosis, and the viral, the warts. We start with the warts. Human papilloma virus-induced warts are very common in children, mainly above 6 years of age, especially in the fingernails, where they often spread from nail to nail by nail biting. The wart may be periungual, appearing as a hyperkeratotic lesion of the nail fold, or subungual, presenting as a hyperkeratotic mass associated with distal onycholysis. Dermoscopy can be very useful for diagnosis of very small warts, as it shows, like here, you see this irregular surface with pointed hemorrhage. Although spontaneous regression of warts is reported to occur in about 30% of cases, treatment is advisable when the lesion causes pain and to avoid its spreading. Next one is the acute spironica. This is an inflammation of the nail fold that follows a trauma with penetration of pathogens in the skin. We see it very common in children's fingernails with the finger sucking. The affected digit shows erythema and swelling, more marked on one side, associated with pain. Abscess formation is uncommon at young age. It's not usually referred to doctor, as its short course does not induce worry. However, when we see severe inflammation, this can give a permanent matrix damage, like onychomadese. Onychomycosis. This is in children is rare. With an overall prevalence below 0.5%, dermatophytes are responsible for the great majority of cases, and predisposing factors are tinea pedis and family members affected by onychomycosis or tinea pedis. Distal and lateral subungual onychomycosis is the most common clinical presentation of onychomycosis due to dermatophytes in children. Superficial onychomycosis in both its deep and its classic varieties is rare and is especially found in young children. When we see very severe onychomycosis, you have to be aware of immune suppression. Interesting thing, children with Down syndrome are more likely to acquire fungal infections of the nail. The diagnosis can be established by means of histology, fungal culture of kalium hydroxide. But it's important to establish diagnosis before the initiation of treatment, because systemic antifungal medications, they have the potential of serious adverse effects, and moreover, no medication is approved by the FDA for the treatment of onychomycosis in children. This is the reason why you always have to perform diagnostic testing for onychomycosis. And as you see here, we have different techniques for that. They have all advantages and disadvantages. And in practice, one should choose the diagnostic testing your lab or hospital has most experience with. The management should take into consideration the age, the causative pathogen, cost effectiveness, and the drug-drug interactions. The gold standard is the oral antifungal, with the literature supporting the use of terbinafine and itraconazole. Under certain circumstances, topical therapy can be used as an alternative, particularly in the setting of superficial white onychomycosis or mild to moderate subungual onychomycosis without onycholyse or matrix involvement. So we move on to the last category of nail diseases, the tumors. Malignant as well as benign tumors of the nail are exceedingly rare in children. The most frequent benign tumors are nail matrix, melanocyte nevi, and exostose. Like you see here, melanonychia refers to brown or black pigmentation of the nail caused by melanin deposition. When multiple nails are involved, one should consider the possibility that it is a normal variant, particularly in the setting of dark-skinned patients. In contrast, when an isolated nail is involved, a neoplastic process is suspected. However, melanoma of the nail unit is exceedingly rare in children. But in these cases of isolated longitudinal melanonychia, as you see on this dermoscopic picture as well, one should periodic follow up these patients. Clinical examination, photography, and dermoscopy. And when you see the band rapidly enlarging or showing different pigmentation or even associated destruction of the nail plate or bleeding, a biopsy has to be taken because histopathology remains the diagnostic gold standard here. So, what is important for pediatrics? I think that is nail disorder as a sign of systemic disease. The presence of changes on multiple nails is suggestive of a systemic cause in a nail child. However, multiple nails can also be affected in primary inflammatory disorders and infections of the nail unit. When evaluating a pediatric patient with a nail disorder, it's important to perform a complete physical examination of the skin, but also from the oral mucosa. Here, it's also important to perform a comprehensive family history as to uncover a possible syndromic associations with nail diseases or diseases that can manifest with nail changes. These clinical symptoms can be suggestive for systemic disease, like pitting, leukonychia, Bose lines, onycholysis, and clubbing. Pitting. This is an interesting one, as this is the thing we most often see in clinical practice. As we already learned in the presentation, PT can be physiological in early childhood, but it can also be suggestive for systemic disease. But in first line, we think as this one, the inflammatory disease, isolated or with skin lesions. So this brings us to this list of diseases. Thus, when a patient presents with pitting on the nails, the evaluation should include a thorough history, a physical examination, as well as an assessment for concomitant psoriatic skin lesions, joint symptoms, atopy, hair loss, and additional nail changes, suggestive of an inflammatory dermatosis, where we can think at alopecia areata, vitiligo, psoriasis, atopic dermatitis, lichen planus. They can all present with pitting. How we do this? So if we see patient with pitting, we do dermoscopy. Like here, we see two different nails. Fingernail on the left. This belongs to a patient with psoriasis, where we see this kind of pitting. On the other hand, we see this fine diffuse pitting, and this is the pitting we see in alopecia areata patients. A next one is the transverse leukonychia. Transverse leukonychia refers to bands of leukonychia that are oriented horizontally or parallel to the direction of the nail plate growth. Most commonly, this recurs as a result of trauma, with accentuation in the central portion of the nail plate and disappearance closer to the lateral edges. It's also reported in association with Kawasaki disease, AIDS, chemotherapy, and also when we see toxic exposure to arsine or heavy metals, and then it's called mace lines. The Bose lines. Bose lines, these are transverse grooves in the nail plates, as you see here and here and here. They can be considered as a minor form of onychomadese, where we see no complete separation. It's a temporary growth arrest of the nail matrix. When you see it in a single nail, you should suspect trauma. But when you see it in different nails, think systemic. Think about symmetric involvement, think about systemic disease. Like, for example, prolonged fever, systemic infection, chemotherapy, and other major illness. Both lines are, as already said, common in young infants, where they reflect the physiologic stress of the birth process. Onycholysis. This describes the separation of the distal nail plate from the nail beds. The process may involve the entire nail plate or only a portion of it. Because of the abnormal loss of adherence of the nail plate to the nail beds, the affected nails, they appear white. The same is here as the same. We see it in a single nail, suspect trauma, or finger sucking. When we see it in multiple nails, one should think about primary inflammatory disorders affecting the nail unit, medications, infections. For example, tetracycline, doxycycline, can cause photoonycholysis. This is a photosensitivity reaction that is well known among dermatologists, but not well documented in children. Now, onycholysis is commonly seen with fungal infections involving the nails as well. So if you see this, don't start an antifungal treatment directly, but perform first investigation. It's always prudent. And next one is the clubbing. Clubbing is an increased convexity of the nail plates. And affected nails, they often appear shiny, and longitudinal ridges may appreciate it in the nail plates. The affected nails may feel spongy and appear enlarged. Clubbing is a key factor of primary and secondary hypertrophic osteoarthropathy, and congenital, idiopathic, and familiar forms of clubbing also exist. In children, clubbing has been reported in Hodgkin lymphoma, congenital heart disease, celiac sprue, juvenile polyposis, and AIDS. Unilateral clubbing also exists. We see it in one extremity or one side of the body. And then it is due to localized vascular or neurological disease. Another nice one is the yellow nail syndrome. This is a disorder characterized by the triad of chronic pulmonary disease, lymphedema, and abnormal nails. The nails, they have the characteristic appearance, which includes the yellow discoloration, the overcurvature both in a horizontal and lateral way, thickened nail plate, and the loss of the cuticle. And also maybe an associated onycholysis can be present as well. The nails, they go slower than normal, and they can be paronychia. Most of the times, multiple nails are affected. Although it's very rare in children, yellow nail syndrome has been reported in infants and in association with fetal heat drops. And in at least a proportion of affected individuals, the syndrome may represent a congenital abnormality of the lymphatics. In adults, yellow nail syndrome may occur as a paraneoplastic phenomenon, but this has not been reported in children. So we move on to melanonychia, which we already discussed a little bit. So it's the brown or black discoloration of the nails. In children, most commonly presents as an acquired isolated longitudinal band in a single nail. And this because of the presence of a melanocytic nevus or a melanocyte activation within the nail matrix. Rarely multiple bands, as you see here, or multiple nails can be involved, and then we see it typically in darker skinned individuals. When we look at melanonychia in multiple nails, we also have to evaluate for systemic cause. For example, medication or a manifestation of a syndrome can also be the reason. So melanonychia in multiple nails is often medication-induced melanonychia caused by medications that stimulate melanogenesis. The development of pigmentation may correlate with the period of medication exposure and usually resolves after discontinuation of this medication. It can be both longitudinal or transverse melanonychia, and this has been reported in children taking hydroxyurea. And this may also cause hyperpigmentation of skin and mucosa. So always good to check the skin and the mucosa as well. It's also been reported on doxyrubicin and doxycycline. Also, nail biting, onychophagia, has also been reported to cause longitudinal melanonychia in children. Also, adrenal insufficiency is associated with mucocutaneous and nail hyperpigmentation because of the elevated ACTH levels, which stimulate melanocyte activation. When we see multiple bands, the differential diagnosis can also include syndromes, like, for example, Poitsier syndrome. And again, when we see discoloration of the nail, always think about dermatophyte or non-dermatophyte infections. So perform clinical investigation here and lab analysis. So this brings us to the take-home messages. What I want you to learn from this presentation: nail diseases in infants and children are uncommon. An acquired nail dystrophy in children is usually due to an inflammatory or infective disease, as nail tumors are very rare. If you suspect onychomycosa, establish the diagnosis before the initiation of the treatment. Thank you for your attention.
Thank you very much, Julie, for this very nice talk. Very interesting. I was astonished to hear that vitiligo can cause pitting. I have never seen that, but maybe I have not looked close enough children with vitiligo. I think there are some questions for you in the chat function. So let's have a look. So thank you for the nice talk. You presented as two different diseases. Would you please explain further about the relation of onychomadesis and Bolines? Would you agree that there are in fact the same disease, but with a less severe presentation?
Yes, of course. So this is the same disease. So it starts with the Bose lines, and when there is a complete damage, the complete arrest of growth in the nail matrix, it gets to onychomadesis. So you have two clinical pictures, but it's one disease. Yes.
Okay, another question is, what is your advice if you want to take a biopsy from the nail bed in children?
My advice is to let it perform by an experienced surgeon, because it's a rather difficult surgery. So you have to know a surgeon who's really talented to do it, because it can cause real damage to the nail. So it's a difficult surgery. So I don't perform it myself in children.
I think that's a good advice. Another question, can you explain why onychomycosis is more common in children with Down syndrome, and what is the effect of therapy in this group? Very interesting. I also was asking myself, why is there any explanation for this?
I was asking myself the same, but I couldn't find anything in literature. But about the treatment, I already had some children with Down syndrome on the clinical practice, and I discussed with pediatrics what we can do about the treatment, and it's the same as in normal children. So you can prescribe the systemic treatment as well as the topical treatments. In most of the cases, it's not a problem.
Yeah, it's also my experience. It works also normal as in other children.
No.
Another question about the treatment of paronychia. Is there a place for systemic antibiotics? Question of Dirk.
In children, it disappears rather quickly compared to paronychia in adults. So most of the time, there is no need for systemic antibiotics. But if it's really painful or you have an abscess, you can remove it and treat with antibiotics after taking a swab to check for bacteria and antibiogram. Yes.
Mm-hmm. You always perform an antibiogram, or you just do a broad spectrum antibiotic right away?
I always perform an antibiogram, but if it's necessary, I start rather away with the antibiotics. But if it's not working, you can change afterwards and know how to treat it.
A question from the audience. I saw twice nail pitting in a child that had an enterovirus infection about 6 weeks later. Is this described?
I didn't find anything about that in articles I read before the presentation. What we see more often is the Bose lines or the onychomadesis because the nail matrix arrest, but maybe it can be possible, yes. But I have no further information on that.
Me not either. Lichen striatus of the nail, also possible without adjacent skin lesion. I think you have said it can be isolated. Okay. Maybe I can ask a question. With respect to melanonychia, you said that rapidly enlarging bands would be an indication for biopsy. What is your interval of control that you would recommend for these melanotic bands in the nails?
My own interval of control is after first time I see the children back after 3 months, after 6 months, and if that's stable at that moment, I go for every 6 months to check. Yeah,
that's also what we do. Okay, last question, because we should move on. I would think more of bolines and not pitting after enterovirus. What do you think? Yeah, I think.
Yes, that was a thing we discussed. Yeah, I think the same. Yeah.
Okay, thank you again, Julie. This was very interesting.
You're welcome.
So we will move on to our next speaker. It's my pleasure to introduce Professor Susanna Szalai from Hungary. She is head of the renowned Department of Pediatric Dermatology at Heimpál National Children's Institute in the nice city of Budapest. She's a board certified pediatrician and dermatologist, and the former president of the ESPD. And she is still in the ESPD board. Her special interest is difficult to determine because she has so many interests and is active in so many fields. But today we will hear her talk about the management of pigmented skin lesions, difficult decisions in childhood. Dear Susanna, the floor is yours. Please unmute yourself.
So, welcome everybody. Thank you for the kind invitation to Barbara and Dirk, and welcome everybody. My topic is about the pigmentary lesions in childhood. I have to say a special thanks to all my colleagues who are working with me, because clinical and scientific work is impossible without them, and special thanks to all members of my department. And I have to say that the photos are mainly or nearly 100% from the database of the last 30 years of my department. I have no conflict of interest. I'm Hungarian, so I have to mention some of Hungarian well-known medical doctors like Ignác Semmelweis, Mór Kaposi, and Professor Heimpál, who is our hospital is named after him. He was a pediatrician, and my former teacher, Professor Éva Török, who was the former leader of the Department of Pediatric Dermatology. I love to deal with medical history, so that's why I'm collecting some things which are related to medical history. So I have this very nice microscope, and I collected a few pots from Venice. This is a pot for Unguentum pediculi, for pediculosis, and the other Unguentum rationalis. So these are very, very nice pots, and I love to collect these kind of things. Our pediatric dermatology center is dedicated in an outpatient clinic, and we are all working and following the guidelines and clinical work of pediatric dermatology. We have a lot of availability with many kind of therapeutic possibilities with photo and bath therapy, immunotherapy. We have a biologic treatment center, and we have plastic surgeon, angiologists. I'm very proud of of the Hungarian textbook of pediatric dermatology. It's a pity it is in Hungarian, but it is full with beautiful pictures from the last 30 years. In summary, I will cover the topic of congenital and acquired nevi, some of our acral nevi and the pathogenesis, pigmented lesions of the eye, nevi at the genital area, which are not so frequent, and a few words about the speckled lentiginous nevus. The topic is very important because 30% of pediatric dermatology consultations are due to concerns regarding nevi. We heard about from the last presentation that, for example, a melanonychia can cause a very huge problem and frighten. The parents are very much frightened. So these are very important questions. First, we have to define which nevus is congenital and which is acquired. And we all know that the congenital melanocytic nevi represent an anomaly in embryogenesis, considered malformations, hamartomas, but most acquired melanocytic nevi are considered benign neoplasms. Depending on how the basement membrane is, there are the junctional, the compound, and the intradermal nevi. The question is the surgical excision. And when you see a nevus, the complete excision is nearly impossible, but in some cases, the resection of portion can be beneficial. For example, this is a case of congenital melanocytic nevus. It's obvious that you cannot remove all parts, And on the other side, the elimination of a nevus cell is nearly impossible because they involve the deeper structures, fascia and muscle and deeper structures as well. When you see a child with a congenital bathing suit nevus, it is very difficult for the parents, and you have to be aware of posterior localization and the large congenital melanocytic nevus, because in these cases, the multiplex satellita nevi, even though if it is 20 centimeter larger, or in adult, among the adult cases, the congenital melanocytic nevus, if it is larger than 40 centimeter, you have to be aware of neurocutaneous melanosis and the central nervous system melanoma. There are some cases when you can remove some parts of the congenital nevus, and it can heal very nicely. Here you can see a very nice result. So the partial resection for cosmetic reasons, it can happen because the parents are pressing you that you must do something. But in many cases, the regular checkup is very important. And for the surgical excision, you have to define the color, the thickness of the lesion, the localization. You have to collect the clinical data and anamnesis. And the parental stress is very, very high in many, many cases. There are some cases when you cannot remove, for example, the upper eyelid. In this case, you cannot remove at all. It is nearly impossible. What about the acral nevi in childhood? It's very important to avoid unnecessary alarm and the unnecessary intervention. So if you see an acral nevus in childhood, for example, this is a child for 1 month, you don't have to remove it. But if you follow or continue the clinical picture and you see that after 6 months, this is the clinical sign, you have to check the child frequently and regularly. You can be a little bit more calm if you see that this is the clinical picture of this child when you see the bathing suit nevus, and then you know that these clinical lesions will appear later on in life. The patients with giant congenital nevi may have many satellites, and these are at the greatest risk of developing cutaneous and extracutaneous melanoma and neurocutaneous melanosis. But these clinical lesions may happen. If we think about the malignant melanoma in childhood, thanks God, is quite rare. The incidence is 0.3 to 1 to 100,000 cases. And among adult melanoma, we have a lot of new treatment, targeted therapies, immunotherapy, and the improvement of overall survival is much, much better. But among children, the paucity of the data on the biology and clinical behavior of pediatric malignant melanoma needs a little bit more focus on this disease. We have to focus on that. Melanoma in children is different than among adults. The prevalence is changing, ranging under 20 years from 1 to 4% till puberty, 0.3 to 0.4. And among the giant nevi. So if you have a look to the articles, you can find very, very different data. It may different at the age and at the size. 1 to 3% of melanoma cases are in childhood. And we, pediatric dermatologists, we do not use exactly the ABCDE criteria, which is present in only 40% of childhood cases. A means asymmetry, B the border, C is color, D diameter, and E enlarging. What do we use for pediatric melanoma cases? We use the ABBCD which means that we see more amelanotic cases. The bleeding is much more frequent, and the bump, when you see a lesion very quickly coming up, or the color uniformity, or the de novo growth, then you have to think about the malignant melanoma. There are different forms in childhood. I mean, there can be the uveal melanoma, the acral melanoma, congenital melanoma, the maternal metastatic form, melanoma of immunocompromised patients, and melanoma of unknown origin. But if you have a look that the melanoma among children is not one disease, there are the conventional melanoma, which is similar to adult melanoma that occur almost exclusively in adolescents. But there is the Spitz melanoma and the atypical Spitz tumors, which occur in younger patients and are characterized by copy number alterations, and the giant congenital nevus melanomas, which are the most aggressive tumors. So these are genetically different, as well, as you see on the right side. So this is more than one disease. Let's go further and speak about the acquired melanocytic nevi. The acquired melanocytic nevi may have a multicellular origin and may participate in the formation of nevus cells. This is very interesting if we speak about these kind of lesions. Let's go further to the pigment lesions in the eye. Maybe you may think that this is not our topic. This can be checked by the ophthalmologist, but in many cases we have to work together with the ophthalmologist. What is the lesion of this in the eye? What is this clinical picture? You can think about, is it an iris nevus, or is it an eye freckle, or is it a lesion nodule, or is it an iris melanoma? If you want to compare, what can you see here? This is a conjunctival nevus. Here you can see an eye freckle. These are melanocytic lesions of the iris, or a lesion nodule, which are clinically not similar. These are the lesion nodules in some cases you may see. And this is a case of an iris melanoma. These are larger and more vascular, these kind of lesions. And you can see ectropial and sectorial bleeding in some cases. So if you have a look, this is an eye freckle. It's very interesting, in a shape of a cross. And this is our case, our patient, what you saw before. So if you have a look, you can be a little bit relaxed, because this is a case of an eye freckle. But the regular checkup is very important in all these cases. So the clinical factors predictive of nevus growth to melanoma in case of age is under 40 years, blood in the anterior chamber, the clock hour inferior, diffuse configuration, ectropion or feathery margins. These are the clinical symptoms of the iris melanoma. But in many cases in childhood, you may see not in another type of pigment. For example, this is a blue nevus, which can be seen in the conjunctiva or in the orbit as well. If you see that this is the clinical picture of the child, here you can see that this is a vascular nevus and the Mongolian spot and the blue nevus in the eye. So this is a case of phacomatosis pigmentovascularis. There are some other cases, nevi at the genital area. What can you see here? The melanocytic lesions of the genital area are quite rare. They mainly arise in the vulva, although they may occur less frequently in the perineum or mons pubis and male genitalia, and represent 10 to 12% of pigmented lesions of white women. There can be melanocytic nevi. In some cases, you may see lentiginous or dysplastic nevi, or of course, melanomas. And this is the most important, what you have to make a differential diagnosis. And there are some other interesting cases. You can see here a nevus, which is a so-called kissing nevus, because you can see double nevi, the kissing nevus for the eyes when you see on the upper eyelid and the lower eyelid. And this is a so-called acral kissing nevus in this case. It is a little bit disturbing and knowing what is going on. And if you make the dermoscopy, it's not a calming clinical picture, but you have to think twice to remove or not. So it's very, very difficult to make the decision. There can be nevi at the genital area as well. Here you can see another nevus. And if you have a look at the dermoscopy, it's not so calming as well. In some cases, you have to remove these lesions, but you have to know that there is the atypical melanocytic nevi of the genitalia. In young women, they may have distinctive histologic features, and in some cases overlapping morphologically with melanoma, but by histology, it's not a melanoma. So by now, there is no evidence that these atypical melanocytic nevi of the genital area are precursors of dysplastic nevi or melanomas. There are some interesting or funny or maybe less so difficult questions. For example, this patient was sent to me by the pediatrician if it is a congenital melanocytic nevus on the penis of this young male. But after 5 minutes, this was the clinical picture. If you can find out how could it happen, it happened that I removed, because I was pretty sure that this is not a melanoma, because the lesion appeared only 1 year before. So this was a case of terra firma forma dermatosis. The problem was that the boy didn't wash this area for many, many months, nearly half year. And till the end, the fifth question is the speckled lentiginous nevus of the face. This is another interesting question. The synonym of nevus pilus, but nowadays we know that it's no longer represent one clinical entity. There are 2 different disorders which can be distinguished. The first is the nevus pilus maculosus, found in phacomatosis pilorosa. Professor Happler wrote and found out this diagnosis. There are dark speckles that are completely flat and rather evenly distributed on a light brown background, resembling a polka dot pattern. And the other is the nevus pilus papulosus, found in phacomatosis pigmentokeratotica. There are dark papules that are of different size and unevenly distributed, reminiscent of a star map. So when you see this clinical picture, you make the dermoscopy and you follow the patient. And if you are quite lucky to follow the patient, you can see. And first you think, is it a lentiginous nevus? Or is it a nevus pilus like congenital melanocytic nevus? And if you can see here that later, many, many years later, I could follow the child. We first removed this one because we wanted to know the histology, and these lesions are missing from here. And you can see here that this is a nevus pilus type congenital melanocytic nevus. And here you can see another patient and the dermoscopy here as well. So by histopathology, the dark spots of the nevus pilus maculosus may show a gentigo pattern. What is gentigo? This means the gentigo is a combined junctional nevus and a simple lentigo. Most of the dark speckles of nevus pilus papulosus are found in compound or melanocytic nevi. What about the development? The propensity to develop Spitznävi appears to be the same type of the types of speckled lentiginous nevus, and the development of malignant melanoma, which is the main problem, the main question of us, has been reported so far commonly in nevus pilus maculosus. By now we know that there is a spectrum of mosaic rhizopathies. Here you can see the isolated papilla nevus syndrome, or isolated nevus sebaceus, papilla nevus syndrome, or Schimmelpenning syndrome, or phacomatosis pigmentokeratotica. And let me share with you my patient. I saw this baby a newborn baby with this clinical picture, and first I thought that this is a nevus sebaceus, an epidermal nevus with segmental, and later on I saw a more segmental oral papillomatous hyperplasia. And as you can see here, later on I recognized that there is a pigmentary lesion appeared. So I recognize that this is a case of phacomatosis pigmentokeratotica. So here you can see the lesion later. She is now at about 14 years old, and this is the clinical picture. So when you see at first, you cannot establish the diagnosis, but later on you will see how it is changing. Why is it important? The mosaic rhizopathies are very important because there is a relationship with cancers, urothelial and rhabdomyosarcomas. And finally, we say that it has a new name for this distinctive binary genodermatosis, the phacomatosis spilosebacea. So this is the new proposed name. For the end, the questions of removal are the big questions: when, how will you follow up? This can be changing from time to time, from patient to patient. There are no regular, you can advise something, but you have to think in all cases. For example, you see a large sized tumor, which is, the question is it a tumor from a congenital melanocytic nevus, or is it a plexiform neurofibroma? And by histology, you can see that this is a neural nevus, which is resembling to neurofibroma by histology. And you have to remove it because it is dislocating the spine. So you have to make the operation. And there are some small-sized tumors which may cause at least the same problem because they are on the face. And even though if it is a small one, you have to decide if it is a Spitznävus, is it a pigmented type or an erythematous type, remove or not. You have to be on top to make the differential diagnosis and to remove it. So when and how to follow up, we always learn, we always try to teach each other. And by now there are no shortcut to the future. We have to climb the tree of knowledge, even though we are very busy among this pandemic situation. But these conferences are helping us. Thank you for your attention.
Thank you very much, Susanna. This was really great, very interesting talk. And I think there are so far no questions for you. Let me check. There is one, our host writes. I can't see it yet, so. Here. I know this is for a question for Julie. So we will come back to this in a minute. I would like to ask you one question, Susanna. When you talked about your institution, you also mentioned that you have a biologic treatment center. And what kind of diseases are you treating? Is it for psoriasis and atopic eczema, or do you also treat other diseases?
We mainly treat atopic dermatitis mainly, but a few cases with psoriasis as well. And now I started to give some biologic treatment for ichthyosis as well, because I always tell to my young colleagues that they will have a beautiful future, because they will have so many drugs in their hands. The most yes, because in the past, in many cases, we could tell the patient that we cannot help, and the child was born with this or that disease, and we cannot help. But nowadays, we have a fantastic future. So they will be much more lucky, the young ones.
So there's one question concerning melanocytic nevus on the scalp. What about MRI, I think is the question. Do you perform, and in what kind of nevus do you perform this?
Yes, it's a very important question. If there is on the scalp, if the lesion is quite small, and if the ultrasound, if we are in the time when we can perform the ultrasound, I don't prefer the MRI. Due to the anesthetic problems. But if the child has a lot of lesion, and if I have a little doubt about if there's a large one with many satellites, it's important to do it, yes, to exclude the neurocutaneous melanosis. And I have a few cases. There are not so simple cases, yes.
So the notion is, if you have one isolated nevus, even if it's a big nevus, it's not such a problem. But if you have satellite nevi, yes, then you have the increased risk of neurocutaneous melanosis and melanoma development, right?
Yes, I know that there are some centers who first send the child to the MRI, but I don't think that it's needed really if there is only one lesion.
Yeah. Right. Any other questions? Maybe I found very interesting your case of a nevus spilus type of congenital nevus. Do you have a certain follow-up of this child, and is there a tendency to spontaneous regression like in the normal nevus spilus?
Yes, it is changing. So the fantastic that you can follow the child, and I regularly check up in every year the child, and then I do the regular checkups and just make the photo and send to lab and ultrasound and so on to exclude any other problems. So I think that yearly checkup is enough.
Yeah. Okay, dear colleagues, anybody has questions to Susanna? Because I don't see any in the chat function.
There was another question that always follow up necessary during childhood. It depends on how is it moving. Of course, if there is a quite small lesion which is not changing, it's not important to check up every year. And if it depends on the parents as well, if the parent is nice and knows what to do, we don't have to ask the patient come every year. But if I see that the nevus is changing and enlarging and many other satellites, then I do a regular checkup, yes.
Yeah, okay. All right. So if there are no further questions, I will close the session and the pediatric dermatology track. I would like to thank you all for your participation and for the interest you have in pediatric dermatology, for your contribution to the discussions. And I hope that this has been fruitful for you and you take something home for your everyday practice. A special thank, of course, goes to all our speakers that have taken the time to prepare these excellent talks and to share their knowledge and experience with us. We really appreciate that. And this is not given. And yeah, thank you to all of you. And I wish you an interesting Congress for all of those who continue to follow the EIP, and a very good week for the colleagues who have been here with us on the speaking board. Bye-bye and stay healthy, everybody.
Thank you. Goodbye.
Bye.
Thank you. Bye.
Bye-bye.